Evaluating mild traumatic brain injury. The process begins by checking if the patient meets any of the following high-risk criteria. Glasgow Coma Scale, GCS, score less than 15. Signs of a basilar skull fracture, e.g., raccoon eyes, battle sign, cerebrospinal fluid leakage from the ear. 2 or more episodes of vomiting. Age 65 years or older. Amnesia of events for 30 minutes or more before the injury. Seizure activity or focal neurological signs. Intoxication. A dangerous mechanism of injury, e.g., motor vehicle collision, being ejected from a vehicle. If the patient has any of the above high-risk criteria, the next step is to perform a head CT scan. If the CT scan is abnormal, the patient should be admitted to the hospital with a possible neurosurgery consultation. If the CT scan is normal, the pathway continues. If the patient has none of the high-risk criteria, or has a normal head CT, the next step is to determine if the patient is suitable for discharge with outpatient observation. This requires checking for the following practical concerns. Glasgow Coma Scale, GCS, score less than 15. Presence of a bleeding diathesis or use of oral anticoagulants. Seizure occurred after the injury. No responsible caregiver is available at home. If the patient has any of these practical concerns, they should be admitted to the hospital for observation. If the patient has none of these practical concerns, they can be discharged for outpatient observation at home, provided that a set of warning instructions is given to the caregiver. A 45-year-old previously healthy man presents approximately 90 minutes after head trauma. He was testing a new bicycle, attempted to stop, hit a curb, fell off, and struck the left side of his head. The patient was not wearing a helmet. He did not lose consciousness and had no seizure activity. Findings: vital signs are normal. Modified Glasgow Coma score is 15. Pupils are symmetric and reactive normally. All extraocular movements are intact. No cranial nerve or focal neurologic abnormalities. The remainder of the examination is normal. Question: which of the following is the best next step in the management of this patient? A. Discharge with follow-up instruction sheet. B. Head CT with contrast. C. MRI of the brain. D. Skull radiographs. This patient's presentation suggests a mild traumatic brain injury, TBI, which usually occurs after acceleration/deceleration trauma. Mild TBI is defined by a Glasgow Coma score, GCS, of 13 to 15 measured at least 30 minutes after the injury. Concussion, a subset of mild TBI, is due to direct force transmitted to the head with possible transient focal findings that resolve spontaneously. Concussion does not usually cause loss of consciousness or abnormal brain imaging findings. Mild TBI can sometimes present with acute confusion, amnesia of events before the injury, headache, dizziness, or nausea/vomiting. Seizures are uncommon and usually indicate moderate to severe TBI. Patients should be evaluated initially for high-risk findings, including GCS less than 15 at more than 3 hours after injury. Suspected skull fracture, e.g., raccoon eyes, cerebrospinal fluid otorrhea. Age greater than or equal to 65. Greater than or equal to 2 episodes of vomiting. Amnesia of events greater than or equal to 30 minutes before the injury. Patients with high-risk features require brain imaging, head CT or MRI. Abnormal imaging requires immediate admission and possible neurosurgery consultation. Patients with normal imaging should be admitted for observation if they have a GCS less than 15, bleeding diathesis or are taking oral anticoagulants, associated seizures, or no reliable caregiver at home. This patient has a normal GCS and no other high-risk features or focal neurologic findings. Patients with no high-risk findings can safely be discharged for outpatient follow-up without head imaging or hospital observation. Choice B, a head CT scan is recommended in mild TBI patients with high-risk findings, but it should be performed without contrast. Contrast can confound the appearance of acute blood because they both appear white on CT. Choice C. When imaging is indicated for suspected intracranial hemorrhage, acute bleeds are often readily visualized on a comparatively inexpensive and rapidly performed CT scan of the head without contrast. MRI provides better resolution for smaller bleeds, but takes more time to complete, is more expensive, and is often only utilized in cases with negative CT findings but a continuing clinical suspicion. Choice D. Skull radiographs may identify fractures but are not sensitive enough to evaluate patients with TBI with high-risk features. Educational objectives. Mild traumatic brain injury can present with acute confusion, amnesia of events before the injury, headache, dizziness, or nausea/vomiting. Patients with high-risk findings, e.g., abnormal mental state, skull fracture, age greater than or equal to 65, persistent vomiting, should receive additional evaluation, including head imaging. Patients without high-risk findings can be safely discharged without patient follow-up.